Greetings from Southern Implant's headquarters here in the US in Jupiter, Florida. While we're waiting for everyone to jump onto the call, it just gives me nice time just to introduce Dr. Egbert. But before I do that, I just want to thank you for joining this webinar. We've got a series of webinars over this period. I trust everyone's well and keeping sane over this time. I know there's a lot of webinars out there, and I appreciate that, again, that you are on this call. Yeah, we're going to have some fun over the next hour. But before I start, I would just like to give a mention and a sign of gratitude to all the health workers on the front line of this pandemic, putting themselves at risk, looking after ill and sick patients. Many of you as well have opened up your doors and seen emergency patients, and all I can say is very much appreciative of that. I know that some practitioners are trying to produce some PPE equipment. I know going to give a shout out to Dr. Rappaport. I know he's printing his own masks up in Seattle and distributing that to some of his clients. Again, appreciative of that. Graham mentioned in his webinar last week that they're also working quite aggressively on trying to find solutions for added help and assistance with regards to PPE. Well, it gives me good pleasure to introduce Dr. Egbert. Dr. Egbert's based up in Utah. I've got a whole arm's length of CV to run through. Dr. Egbert did say, just keep it brief, just keep it simple, keep it to 3-4 points. But Dr. Egbert received his dental degree in Creighton University in Omaha, Nebraska in 2008, and an MDS, an Advanced Prosthodontics Certificate in American College of Prosthodontic Board of Certification from University of Tennessee in 2011. As I mentioned, he maintains a private practice and surgical prosthodontist as the reconstructive dental specialist in Salt Lake City. In his spare time, he enjoys skiing and spending time with his family. I would emphasize he does enjoy skiing, but he's very good at it. I think it should maybe even be a career. Dr. Egbert, what do you think? But before I hand over to Nick, Dr. Egbert, I did see, the first time I saw his presentation was at the corporate forum at the AO meeting in Washington, DC. And I know he's a big attraction to our conference later this year in November in South Africa. So please earmark that in your diaries and get more information on that. Well, further ado, I'm going to introduce you to Dr. Egbert, and very much looking forward to this presentation. The presentation is titled Optimizing Quality, Efficiency, Economic Treatment Options in Private Dental Practice. Dr. Egbert, over to you, sir.
Thank you, David. We're going to go ahead and get started right quick. Keep this short and quick here. So about 25 years ago, my brother, who's now an oral surgeon that I work with a little bit, started a landscaping company. And the way we put ourselves through school was mowing lawns, and then gravitated into building fences and decks and things like that. And so this picture was from over 20 years ago. My expertise per se was building these gates where we dado out the cross members and everything else and make the strongest, neatest, best looking fences and decks around. But we live by the adage of measure twice, cut once, plumb level square. But prior to doing any cutting, we drop a blueprint. We learned real quick that you have to be very accurate and precise in calculating the cost of the materials, the time on the job, and so on and so forth. We used what was called the project management triangle to kind of estimate the cost, the time, and the scope of the job. This is also called the triangle of constraints, meaning it models the constraints of any given job or nowadays treatment with the amount of time that we're putting into the project or the case and its cost. In other words, and of course, obviously not wanting to compromise on quality. In other words, though, for any given treatment or job, if we want to shrink the time, we're going to have to pull some guys off the job, maybe out of the lab, expedite the cost of materials, and increase costs. If we want to shrink the cost, we may have to increase the amount of time for the project or change the scope of the project or treatment, say, from fixed to removable. Otherwise, we may end up compromising quality. This is also referred to as the unobtainable triangle, meaning that it's unobtainable to save money, save time without compromising quality. Our blueprints have now changed into CT scan cross sections and measurements, our gates into immediate implants and crown preps. But the unobtainable triangle remains the same even in dentistry. My hopes today is that we can discuss how innovative engineering may allow us to break this unobtainable triangle for the better. We're going to jump right into this. One of my passions in dentistry is treatment planning. We recently wrote an article with the doctors over at the University of Utah, Dr. Halper and Dr. Durham. Of course, they did most of the work. I just provided the pictures. But the key question here is to ask our patients what exactly that they want. And the things in my practice that I've heard are, hey, I want beautiful teeth. I want to be able to eat. I want a good bite. No one really says they want cheap dentistry in my experience, but they don't want to be taken advantage of. So they want good value. They want comfort. They want things to last. I hear all the time, I don't want to wear a flipper. I don't want to wear a denture. And I don't want to have to do this again, doc. And of course, a common one out here in the US is, I don't want this to hurt. So think about the patients in your practice and what they want. What do we want as clinicians? We want to optimize the ABCs. This is a mnemonic I started way back in residency of optimizing aesthetics, biomechanics, and biology. We want to optimize cost, comfort, cleansability. If we don't, we hear about it from our patients. Of course, we want things to last as well. We want things to be done efficiently. We want to manage patients' expectations. Future treatment, we want to be able to do easy, low cost, low stress maintenance and future modifications. And of course, we want to do this as safely as possible. If you kind of think about it, patients and doctors want the same thing. We call these the ABCs of treatment planning and the ABCs of communication. We all have heard this, patients don't care how much we know until they know how much we care. They don't know how much we care unless we speak their language. So just as I instruct the residents just a half day a week over at the hospital to figure out what's most important to your patient and in their words, reiterate how you're going to help them accomplish that and give them that, and you'll build rapport quicker and have a higher case acceptance rate. So we're going to jump right into our case of the day. This is Kate. She came into our office last year on her third visit, said she has loose teeth, ugly metal gum line, an allergy. I put that in quotations. That's common, whether it's a true allergy or not. If you don't respect and accept that and help guide the patient through options, you won't be doing the case, which is why she's here for a third opinion. So what does she want? Well, we asked, Kate, what's most important to you? She says, I want beautiful teeth. I don't want to see this metal at the top of my gum line. She also wants, of course, this to be comfortable because she's tired of having this bridge splinted together in her mouth, and she does not want to wear a flipper. This is all in her words. Of course, as clinicians, we want to optimize all the ABCs, but we're going to focus our communication on optimizing aesthetics, comfort, efficiency, and expectations. However, we're going to use her words. Kate, we're going to use the minimum amount of metal in this treatment. We're going to do everything humanly possible to avoid any bridge work and keep you out of a flipper. So again, we don't know unless we ask. So I don't have time in this webinar to go over the entire treatment planning process of anterior teeth here in the aesthetic zone. But to simplify the diagnostic information here, you just want to diagnose the patient from superficial to deep, right? And it starts with the patient's aesthetic expectations or their psychology. Then you move to lip line, tissue type and form, tooth type and form, and you arrive at this diagnosis on whether this is a high-risk patient or not. Of course, then we delve in deeper into the CT scan and diagnose bone type and form. So, I put a question mark on D4. This is soft bone. We're getting Hounsfield units in the 180 to 200 range. I don't use this for an official diagnosis of bone density, but it does give me a clue as to what to expect when we drill into that bone. So we're going to need to use an implant and a surgical technique to optimize stability in this softer bone. As we move into the right central incisor, we have a little bit more dense bone, but less bone volume at the crest. And of course, the red hash line and the green hash line are showing the disparity between the appropriate surgical angle or optimal surgical angle and optimal restorative angle. Moving on to the left, central incisor, a little bit better bone density, compromised bone volume at the crest, disparity between the surgical and restorative angle. And to our lateral left incisor, softer bone. You can tell by the radiolucent bone alone. And also we've got a disparity again between optimal bone surgical angle and screw retained restorative angle. So keep in mind she's wanting to minimize metal, no bridge, no flipper. So why is she here for a third opinion? Well, her first two opinions and consultations propose this conventional treatment, which is how we would have treated this patient back in residency. Of course, exam, scan, workup, and do IV sedation, extractions, grafting, put a flipper in her, transitional partial denture. Of course, we'd see her for a 2-week post-op, a 4-month post-op, and then we do another round of surgery, implant placement, grafts if needed, and reline her flipper. Do another 2-week post-op, 4-month post-op, we'd then do an uncovery and reline her flipper. Move on. Of course, if I was only the surgeon in this case, we'd then send her to a different restorative doctor who would then have to do his exam or her exam and make impressions, deliver provisionals, mold the tissue, come back in 8 weeks later, make another impression, deliver the bridge. All in all, the problem is we're looking at 14 plus visits, 15 hours, and in over 12 months. This patient was a hardworking person who didn't want to take much time off work, and so that was her main concern. And we worked up her treatment plan. This is even with insurance rates. She wanted to also do restorations on her first bicuspids and cuspids on both sides. And the question I have is, what would this outcome be like if we were to do multiple surgeries? This is why she's here for another opinion. But of course, her chief concern was no metal, no flipper, no bridge. And this treatment plan that the previous doctors gave was flipper, 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 bridge, not to mention multiple surgeries. So sometimes in private practice, the most costly cases are the ones we don't do. In residency, and we've known this for 20 years, great articles written by Dennis Tarnow 20 years ago talked about the bone crest and papilla relative to implant spacing. And we've always been cautious at putting adjacent implants in the aesthetic zone in fear of that recession. Even if we'd done this bridge, which would have been difficult in this case with the soft bone to immediately provisionalize, we never would have really had a chance to do it because the patient's not accepting treatment if we do a bridge. Another option in the aesthetic zone here would be to place implants in the central incisor to still be dealing with the same papillary recession and potential loss of bone crest. We may still have some decent papilla on the mesial of the vital teeth, but of course we're going to be competing with thin bone volume at the crest here, and we're never going to get a chance to find out because the patient doesn't want to do a bridge. I'm not advocating give in to patients' desires every time, but if we have a way through techniques and innovative materials, implants, to give patients what they want without compromise or in fact optimizing outcomes, then let's do that. We know from articles, a systematic review by Chen and Busser here, over 1,600 titles of immediate implant placement in the aesthetic zone, that it's doable, high success rate, but we do have to be concerned about recession of the midfacial mucosa. This is a patient that I treated about 7-8 years ago, and 5 years later we have this obnoxious recession at the bone crest here. So I did this case exactly how I was taught in residency, but we're going to chalk this up to using a platform that's too large, causing avascular necrosis over time and loss of that recession. So you can imagine how tragic that would be for Kate. Her main concern of coming in and getting treatment is to get rid of this metal gum line. And a few years after implant treatment, if we have yet again a metal gum line with more recession, that would be a miserable failure, especially on a patient that has a high aesthetic expectation. One of the best review articles I've come across and this is the one that I like to teach with in our residencies and CE courses, is this 10 keys for successful aesthetic zone immediate implants. This was published in 2017 in Compendium with an all-star group of periodontists and prosthodontists. This is a case we did implants 7 and 10, well, about 8 years ago, and still have great results, long-term results by following this plan. Step 1 is the aesthetic risk assessment. We kind of talked about that, evaluating tissue, bone, and tooth type form. We obviously are going to take a CT scan and verify that we have a facial plate. Also, common sense would say, where's the root position? What does the alveolar form look like once this tooth is out? Do we have adequate bone to place this implant in a restoratively driven position? We're going to do this flapless, of course. We're going to do everything we can to do a flapless extraction and implant placement, placing good available bone. That's kind of a given, but more apically and palatally positioned to protect that buccal plate or facial plate, and do some grafting so we can preserve that good tissue on the free gingival margin long term. One of the things we're doing to accomplish that, and the trend is to go with a narrower implant, 3.3 to 4.3. So this is narrower than we were used to placing 10 years ago in residency. That was back when we believed, hey, if we get the cross section of the implant roughly the same size as the tooth root diameter of 2 millimeters deep, the CEJ, we should get a good result, but we weren't accounting for the biology, which always rules. So narrower platforms. That allows a larger buccal gap to graft. We can graft that with DBBM or FDBA. According to literature, there is facial gingival grafting if needed, but the most important part of this is to do an immediate contour management with the screw-retained immediate provisional. There are recent studies that show excellent results without facial gingival grafting. I know that's something that my periodontal friends don't want to hear, but the patients really enjoy less invasive treatment. So these articles that show no need for the tissue grafting would be this dual zone therapy, published all the way back in 2012 and on. This is Dr. Stephen Chu, Dennis Tarnow, the Salama brothers, big names in implant dentistry, that show if we graft bone all the way, not just the bone zone, but also the tissue zone, we can encourage a biotype conversion. So we can assume that everybody has a thin tissue biotype when we do these cases, whether it's thick or thin, and try and promote as much good tissue as possible by grafting all the way down to the tissue zone. Best way to manage that and hold the bone graft in place is with an immediate provisional, but obviously we need the immediate stability to do that. And all too often in my career, we've kind of gone one size larger than I wanted to get excellent stability, but then we run the risk of our midfacial recession long term via avascular necrosis. So we don't want this to happen. A great study to show kind of side by side, when I met Dr. Amato at a meeting a few years ago, a wonderful clinician that did a study, took 4 different groups of 20 patients each, did an extraction, immediate implant, healing abutment, extraction, bone graft, healing abutment, extraction, immediate provisional, and then the last group, of course, extraction, immediate implant, bone graft, down to the tissue zone, immediate provisional. And of course, in this study, in my opinion, the standard of care for extraction, immediate implant, dual zone technique, and immediate provisional. As we move through the evolution of implant design to make this more predictable for the patient and for the doctor, we start out with traditional tapered implants, where the surgical axis and restorative axis are the same. In 2002, Dale House, one of my heroes in implant dentistry, invented the coaxis, which is a subcrestal angle correction. All we did was angle the abutment screw, which allows us to put the implant where the bone is, but have the platform where the tooth is. The problem is we'd still have issues with midfacial recession. So all we've done with a body shift and a subcrestal angle correction implant design is shrink the platform of this implant. And when I first saw this, I thought there's no way this is going to work. But when you think about it, even in traditional implant therapy, like the tapered implant, you should never, ever, ever put that implant body platform against the facial plate. And so that's technically, at the time of placement, not being used for primary stability. So why wouldn't we shrink it, not have it be a liability and increase the graft? And the thought process behind body shift. To simplify this, all we've really done is anytime that you're doing an immediate implant and you're thinking, hey, I wish I could just put a 5mm implant in this socket, I'd for sure get primary stability, but then you're cautious about it because now your platform's too large, that's when you'd use one of these body shift implants. All we've really done is crossbred a 5mm and a 4mm implant to have a 5mm body and a 4mm platform. So think about this, if we increase the diameter of the body, we increase bone implant contact, which should increase initial torque value. Torque values are strongly correlated with success rates, so we should increase the success rate, but also significantly increase the chances of immediate implant, immediate provisional, or immediate provisionalization. If we shrink the diameter of the platform, we now can increase the size of our gap graft, which allows for better bioconversion, as in more stable tissues, increased chance of doing an immediate screw retained provisional with the sub-angle angle correction, and also we should see less recession over time. And these come in different sizes, of course, diameters and lengths. We spend a lot of time focusing on this facial plate, and sometimes I think we neglect the interproximal distances with this implant, placing implants in the aesthetic zone as well. This is a case that a very well-respected referring doctor of mine operated and had some issues with. We obviously lost papilla between the cuspid and the lateral. As we look into this case, we see that the implant was placed a little too close to the facial plate, obviously too close to the cuspid. The reason being is we feel pressure these days to do teeth in a day. That's what all the billboards say, that's what all the commercials say. And so this is a case where we chose an implant that was a little too large in diameter, obviously feeling the pressure of doing an immediate extraction, immediate placement, immediate provisional. So if we'd had an implant that was larger at the body, narrower at the platform, this may have never happened. Of course, we had to remove this implant. We have a substantial amount of vertical bone loss on the mesial of that cuspid. So of course we graft, tissue, graft, and of course the patient's now in a dreaded flipper. We then come in a few months later and do a flapless surgery with a coaxial implant, good D1 bone from our graft. This is going to be a 12-degree angle correction, which is allowing us to get a screw retained provisional and hope we get some tissue. Of course, with the extensive vertical bone loss on the cuspid, we're not anticipating getting a whole lot. Talk to the patient about treating the adjacent tooth, more tissue grafting, things like that. But this is the difference, between success and failure in the aesthetic zone. One size implant, so 1 millimeter larger platform, 1 millimeter to the distal, resulted in a $10,000 lawsuit and a failure. So it's not that aesthetic zone implants are terribly difficult. It's just the risk is higher, and that's why they're considered high risk treatment. Everything basically needs to go perfect, or we'll have a compromised result. So for this patient, we were able to salvage the case. We told her, don't lift your lip any higher than that, and we'll get a good result. Unfortunately, when she smiles, she does. Prescribed a little Botox to the lip so she doesn't show it, and ultimately she was happy after 18 months of redo therapy. So the reality is, in private practice, the most costly cases are our redos. We want to minimize the number of these redos. In fact, in our 10 keys for successful aesthetic zone treatment, the authors advocate, if you can't get that implant in the ideal sagittal root position, then you should abort the case, right? It should be aborted. So sometimes you find yourself, do we compromise the surgical? Do we compromise the restorative angle, or do we abort? The beautiful thing about body shift implants and subcrestal angle correction is we don't have to compromise. We don't have to abort. We can put a larger diameter implant where there's more useful bone. We can shrink the platform where there's less bone volume, increase the gap. We can respect the biology and the patient's desires. This will lessen the number of no-dos and also lessen the number of redos. And we can do neat things like we've been told are unpredictable for the last 20 years, such as adjacent implants in the aesthetic zone. So we're going to run through, I don't have time to go through every single surgical step, but if we want to do non-invasive or less invasive extractions, use your periotome. These are short roots. an ideal case to do immediate implants on. I personally like using a Lindemann burr. Some people use a round burr, I know. Ultimately, we just need to start the vector of this surgical osteotomy against the palate and not allow the bone density to drift or deflect our drills into less than optimal positions. This is our 12-degree angle correcting pin. So as opposed to the straight angle correcting pin that a lot of us are used to, we're evaluating our angle correction. So these implants are actually placed at traditional angles, but then we allow the angle correction to do the work. And so we want to verify that those are coming right through the cingulum. This is the final drill. I highly recommend using the inverta-specific drills in these situations. And here's our implant with more than 50 Newton centimeters of initial torque. And I always evaluate that from the facial and also from a sagittal plane. As we move on to our right central incisor, more of the same. We know we have kind of a thinner bone volume crest. We want to make sure that we nail the depth on these implants, okay? This little hash mark right here, if you see my cursor right near the gum line, is the 6 millimeter mark. No, we're not placing these implants 6 millimeters deep. We're placing them 3 to 4 millimeters deep to the predicted free gingival margin. But with these implants being larger in diameter and more tapered, they're going to exponentially torque out faster. So you have to make sure you do not under drill. If anything, my recommendation is over drill length by a millimeter, even 2, with everything but your final drill. I use my depth gauge quite more often than I used to, just because if you bottom out with these type of implants, they're going to exponentially increase in torque, and you're going to struggle to even get them back out and get them to the correct depth. So be careful with these, but make sure you place these 3 to 4 millimeters deep to the anticipated free gingival margin. Again, great torque values in D3 bone. As we move on, I'm always double checking with a suck down matrix. I even like to get crazy, put some temporary cylinders, because those never lie on where you are relative to the screw access position. It's a totally different ballgame, doing immediate implants and having to get the immediate stability to do immediate provisionals. And where we're going with this is final crowns delivered a week later. But long story short, we want to go in and out with our matrix. You can call this guided surgery if you'd like. This is all we need. I'm skipping the final drill on this one because, again, this is super soft bone, and we're going to go in with our inverta. One thing to avoid, this little scribe line is showing where the front lobe, if you will, of the implant is. Traditionally, we're told just put those on the facial. That's not necessarily true. The best way to find the appropriate rotational orientation of this implant is to put a long thumb driver in there and visualize where that screw access is in that abutment screw. So you can, again, we don't have time to go over the long-term theory behind implant depths, but if you take all of these definitions on how deep to place an implant, they all essentially say the same thing: greater than 3 millimeters, but less than 4 millimeters to the predicted free gingival margin, not the existing. Some you may graft, some you may need a countersink, but push that gingival margin where you want it with the depth of the implant. So now we're to our lateral incisor. Again, softer bone here. We're going to skip the final drill. Since we have softer bone, if you want to use Versa drills, knock yourself out. But like I tell the doctors that we train and residents, you can always drill more, but you can't put it back. So another good example of not necessarily putting that orientation groove direct facial. I would honestly just forget that that's even there. Put your long driver in and rotate that implant until you get the desired screw access vector or restorative vector. So we used to do immediate temporaries directly in this situation. Now with an incredible lab technician, CAD/CAM, close proximity, we're now grafting these sites, again, all the way to the tissue zone. I still use the FDBA mixed with some of the patient's autogenous bone from the osteotomies, and I'm just making an impression, send it to the lab, and 2 hours later, sometimes they come back 2 days later, depending on the logistics, we've got a really nice PMMA temporary. Now, the 3 materials that tissue is proven to attach to in these situations are titanium, zirconia, and acrylic. And so acrylic doesn't sound very fascinating or glamorous, but it does, in theory, have tissue attachment. So this particular provisional is titanium and acrylic. So yes, this is a bridge. I felt safer with the softer bone density, you know, to splint these individual crowns together for the temporary. Of course, we had this discussion with the patient on the front end, but we were able to minimize the metal, keep her out of a flipper, and she was really happy to go from here to here in the same day. So what patients are really wanting these days are aesthetic, accelerated, alternative treatments to the conventional. These are very predictable provisionals, very strong relative to directs, you know, injectable materials that we're used to using. We bring this patient back at 4 months, make our new impression. I do splint. Now, one of the tough things prosthetically is to manage the contacts in adjacent implants. Anybody that's done implants for more than a year knows that. So I do go in and I loop these together with this neat light cure acrylic material that we've come across. We can talk about that later. Open tray impressions. Make sure you pull those impression coping screws out so that they don't get caught up inside the screw pattern of the implant. And then we move on to our abutment selection. So I personally put my analogs in. I teach other doctors and residents to do this. That's your quality control. I also deliver the abutments to the lab with screws, so there's no question whatsoever on what was used in the case. One of the biggest problems we have in America these days is the use of generic parts. And to defend the doctor, sometimes they don't even know that that's happening. But just remember, this patient's key concern is when we're choosing what abutment and the type of crown to put this together is minimize the metal, and I have an allergy to metals. You know, whether she has it or not, you know, you have to acknowledge that. And so our abutment options are an old-fashioned UCLA abutment that we wax up and cast, lots of metal. A prefab titanium abutment, that's kind of a cheap, easy, don't have to think about it. The problem with these is we can't control our emergence profile that we've worked so hard to develop and maintain tissue, and also have a cemented margin. This is our of course, our tie base, which is fantastic. You know, we can control the emergence profiles, but anybody that's done hundreds of implants will know that we eventually get tie-based delaminations. And the way I like to explain this to the residents and doctors we teach is, if you feel comfortable cementing a crown to a crown prep this size, then you feel comfortable, you know, with a tie base. But we've had too many problems of tie-based delaminations. So in my experience and opinion, the best option would be to use what's called a passive abutment. And if you look at this, this is the M squared, more metal, more money, as we go from right to left in this situation, which really doesn't optimize patient desires nor our ABCs. So what we do is we CAD-CAM design the screw retain crown. Thanks to the subcrestal angle correction, we've got a screw retention right through the cingulum. We then can mill that out of zirconia, thanks to P.O. for this cross-section that he made. And then we can place the lab can place the passive abutment. So we have like versus like materials. When I was in residency, we learned real quick that zirconia doesn't do well down inside of an implant connection. And so we want a titanium, at least a titanium like washer or spacer in the implant to reduce wear. The difference between the passive abutment and the tie base, however, is that in the passive, the screw is actually compressing the zirconia, not the tie base, so we don't deal with delaminations. This is similar to angulated screw channels, minus the angle, but we've had some issues with their angulated screw channels are great. However, we can't get the same preload, and there's not an option to do immediate temporaries, as far as I know, predictably, without having the lab use a final abutment, so that increased cost. But more importantly, an angulated screw channel increases the size of the screw access, which obviously doesn't make the crown any stronger. We're also competing with non-axial loading of the implant. When we place these implants at angles, and the platforms at an angle relative to the occlusal force, we're putting upwards of 59% more stress on the implant platform. And it takes 3.5 times less force to lose preload and have a screw come loose. All right. This is a case where that we did about 7 years ago, where we place a competitor's implant, nice implant. We didn't believe in going much tighter than 35 to 45 Newton centimeters. We have a beautiful screw access right through the incisal edge here, which means we're not going to be able to do a screw retained crown at the time. So we do a cement retained crown. Not the best result. Didn't do the bioconversion, used too large of an implant, standard recession. Patient comes back 2 years later with a loose abutment. And of course, probably that has something to do with the 59% more stress of the platform and less preload to make that loosen up, that abutment screw. So of course, we all know we need to unscrew that, make a new impression, put it back on, bonds and composite, remove it again, and now we have our saving grace is this angulated screw channel. However, if you look at the size of the screw access, we have unsupported porcelain in this restoration. Of course, this is fun. We were able to overcome this situation, and 2 months later, the patient comes back with sheared porcelain. So now we're redoing this twice, okay? And then here's our tie base stuck down inside of the implant. So I choose to hopefully avoid this situation as much as possible. This isn't the only time, it's just the time where I was able to document the case. Of course, later I stumbled across this article that says a widened channel may cause thinning of facial ceramic. Not sure why I need an article to, confirm that a thinner crown isn't as strong, but I'm going to choose subcrestal angle corrections and passive abutments moving forward here. So here's our case, our milled crown. These are our crowns with minimum metal, no allergens. This is grade 4 pure titanium on these parts. It's not an alloy. We can remove her preps. And these are her crowns that we're going to deliver. Kind of a neat demonstration on how we were able to mold the tissue with appropriate surgical technique and appropriate temporaries. I've been doing this for the last 10 years now, and we're not getting this nice, perfect scallop. We weren't getting it near as frequently as before Inverta and using acrylic provisionals. But we can go ahead and we can torque all those down. Of course, we're in America, we like super bright teeth here. This is what the patient wanted. But the real miracle here is evaluating post-treatment, if you will, the volume of bone that we're generating around these body shift implants. And this is something I've followed up all my aesthetic, as many as I can, as patients will come. And usually we're only seeing 1 to 2 millimeters of bone around our traditional tapered implants, but with these Invertas, this is the best of both worlds. It's like getting primary stability with a 3-5 implant and having just gross amounts of bone to the facial. And so in theory, long term, if the bone sets the tone and the tissue is the issue, is kind of the coin saying, the more bone and tissue we have, the better chance we have of tissue preservation and tissue aesthetics long term. So if we look at our central incisor here, great amounts of bone, you can make an argument even more than when we started. The one that I'm a little concerned about, hence the caution yellow, this is what I'm used to getting throughout my career with traditional implants. Of course, we started with, this is probably the most compromised site, so we'll have to keep an eye on that left central incisor. But of course, as we move to the left lateral, tons of good bone with what we started with there. So that's not the only case. I don't want to get in here and lecture about one case, N of 1. Here's another one with great bone outcomes. These are all final restorations. Don't love the contour emergence profile of this one, but great bone density around all of these. These are all cases that we've completed in our office. This is upwards nearly 4 millimeters of bone on the facial. That tissue's not going anywhere. This is one we finished just a couple months ago. This happens to be the picture from the slide. But basically what we're showing here, this is a neat case because we delivered final restoration 7 days later. Because of that incredible amount of initial torque value from these Inverta implants, we're much more comfortable and confident torquing down restorations early. And we can also do full arches with this. This is another case of lateral incisors where we were able to do kind of this 3/4 arch. This will be a great split mouth design to follow over time between conventional sinus grafting and avoiding sinuses with immediate molar and angle correcting implants with a 3/4 arch zirconia. This is incredibly important with these patients like this sweet patient here with high smile lines and gummy smile lines. This would be incredibly difficult to manage with traditional implants and not see the recession. I suppose you could quit and just table the bone as well, but by the time you remove enough bone to hide her transition line, you'd be all the way up, you know, near the nasal spine. So back to Kate here, we were able to optimize basically all ABCs. From a clinical standpoint, she's extremely happy with the outcome. We were able to do this in 5 appointments versus 14. We were able to do this in a total of 8.5 hours of chair time versus 15 plus in 5 months versus the 12. No flipper, no bridge, and and all of this for almost $2,000 less than the conventional treatment. And you can make an argument that this may have yielded a better outcome in providing aesthetic accelerated treatment alternatives. Well, this is where a lot of doctors chime in and say, yeah, but you know, how much do these implants cost? And my response to that is, what is your time worth? Of course, these implants are more money, you know, they're more expensive. But if you can cut your treatment time in half, and more importantly, increase case acceptance, it's a great investment into the practice. So I like to look at this like this, and you know, these are my numbers. So I think all of you, I challenge you, because the things are a little slow right now, figure out exactly what your fixed costs are per hour in your office. In my office, if you add up, you know, taxes, staff wages, sundries, and your lease, divide it by the numbers you know, you're in your practice, we get a $303.11 per hour. On average, it's $100 per chair per hour in an office. Is a good starting point, but you need to figure out where that is. So this case, just the fixed overhead cost alone costs us $2,500. Now contrast that with the 14 plus visit conventional treatment, and we take that figure times it by 15. We actually are saving money with the efficiency of this implant. So if this implant costs $100 more per implant, of course, in this case, that's $400 more, but we're still obviously in the green by $1,500. And you also have to contrast that with, you know, this patient wouldn't have moved forward with treatment had we not been able to do individual implants adjacent in the aesthetic zone and immediately provisionalize them. So you have to buffer this with the cost of a no-do, which is thousands, okay? Profitability per hour, conventional versus accelerated therapy. This conventional therapy, of course, it makes us feel better, you know, because we have a higher net, if you will, in the case. But if you divide that by the 15 hours of chair time, and subtract your fixed costs, we end up with $870 an hour. And again, these are my numbers. You need to plug in your own numbers here. Accelerated therapy, ironically, we're charging less to the patient. We're paying more for implants because we're doing 4 implants more versus 2, but we are doing less grafts. So technically, there's less of a total net profit. But if you divide that by the hours in the case, our profit per hour is almost double. And the way I like to look at this is you can almost do 2 of these cases in the time it takes to do 1. And patients are happier because it takes less time and they never go without teeth. So my question to ask is, think about this. What is your time worth? Of course, all this talk about money is kind of taboo until now with this global pandemic and recession. We want to be you know, an efficient practice, as profitable as we can, without, of course, compromising the ABCs and compromising treatment. But perhaps we're able to obtain the unobtainable with these new implant designs. The inverta, the passive abutment is half the cost of a lot of even other abutments. So, you know, this is part of our research team. You know, we've got the New York team, Dennis Tarnow, Stephen Chu and his group, Barry Levin, Mike Wills, myself. Looks like I have the lowest batting average of these, but we have just between the 4 of our practices, 282 implants, 98% survival. Worldwide, since 2017, we have over 2,000 implants out with high survival rates. These are all the doctors that I've been involved with the research project, all more talented and more intelligent than me. I'm grateful to be part of the group. But these are really changing the way we're able to do implant dentistry and accelerate therapy, really at the same time optimizing treatment. I don't have time to go through the other cases, but this is kind of a little teaser for what we'll be presenting in South Africa in November. But these numbers that we talked about on this case are extremely interesting to go over on removable cases as well. Coaxis implants, inverted implants, can also be used in the mandible. This is a 12-degree coaxis inverta going in to mitigate the submandibular fossa. Anybody that's placed implants in the bicuspid region, molar region, in the mandible, posterior mandible, knows that occasionally you'll be placing that implant and suddenly it reclines on you because the tip of the implant's hitting the submandibular fossa. Well, you can anticipate that, you can mitigate that, and you can place coaxis implants in the mandible and correct basically at the reclination of the mandible, but still get perfect parallel restorative platforms without the use of multi-unit abutments, which is great. We'll talk about that a little bit more in the next lecture. Also, larger diameter implants, so implants that are able to be placed immediate in molar sites when there's not enough interradicular bone for traditional implants. These 7, 8, even 9 millimeter wide implants are fantastic. Of course, you abide by the exact same rules here. Never against the buccal plate, graft 2 to 3 millimeters of bone on the buccal there. But we're using these with great success and have for over 10 years now. So this is a patient that initially wanted to do fixed, switched his mind, went back to removable, but we're able to optimize kind of cost for the doctor and for the patient. Lastly, with fixed full arch, we're able to even use 24-degree angle correcting implants and completely avoid the use of multi-unit abutments if you like. We are in the process of doing these milled titanium bars with individual layered zirconia crowns. So we're able to provide real good outcomes for patients, accelerated with easy modifications and fixes over time. In summary, to wrap things up here, this is the article that we recently published, More of an Art Than a Science, Effectively Relating to Patients on a Subjective Level. So think of the patients in your practices for the aesthetic rehabs, the full arch removable and the full arch fixed. It's just as important to the patient for them to know that we know what we're doing as to relate to them on a subjective level. So the key to success here is to give honest recommendations, including cost, advantages, disadvantages, and treatment alternatives, all in efforts of elevating the standard of care for the complex implant patients. Remember, identify and prioritize what's most important to your patients. Moving forward into times of economic uncertainty, it's incredibly important to increase our success rates of patients moving forward with treatment. So ask them what's most important to them, find a way to give it to them. Of course, optimize your ABCs and minimize your costs, maximize your efficiency, but you won't be able to do that without the appropriate tools, immediate molar, angle correcting implants, inverted implants and passive abutments, and provide your patients with aesthetic accelerated treatment alternatives, and hopefully obtain the unobtainable. I appreciate your attendance, and we will now open for questions. Did it, David?
That you're doing your private practice as well as with the beta group, and it's truly inspiring, and we're getting a lot of information, data on these processes. Yeah, absolutely. Let's open up for some questions. I do see there is some questions at the base. Bear with me 1 second.
Am I good to go, Dave?
Yeah.
Okay, we have a question here. How do you manage the scenario when the facial bone is preserved due to placement, but the palatal plate is compromised due to surgical drilling? I mean, a simple answer to that is to do your best not to compromise the palatal bone, but treat the palatal bone the same as the facial plate. I mean, obviously you do an immediate gap graft in that situation. If you've blown the plate, then you would need to, hey, that's, my phone's ringing, that's good. It means patient. You would need to, tentatively use a tissue membrane, manage it the same way you would if you'd lost the facial plate. I hope that answers your question on that one. Another one, let's see. Oh, okay, that's not really a question, that's a comment. Let's see, a good question. What's your take on socket shield with the inverta? I'm a little bit conservative. I unfortunately have had the wonderful experience of being asked to be an expert witness here in America litigating some cases. One case, a doctor actually left part of a root tip in and lost a lawsuit. And so do I believe that the socket shield technique is a viable technique? Sure, as long as everything done is fantastic and well. I don't believe in my demographic area, I'm not speaking for the entire United States, that it is the standard of care. And I think you'd have a hard time defending yourself, leaving some of the root in the socket. It's that simple, and it's just so easy and predictable to remove. In my experience, it's more predictable to just remove the whole tooth than it is to try and mill around it and leave a potential for infection. I also look at it from a risk standpoint. If that socket were to get infected, then you lose the implant, the graft, the abutment, the crown, and you start all over again. So in my personal demographic, we don't do the socket shield, but I'm really impressed with the results that other doctors are getting. Hopefully that answers that question. Where can we get access to the recording? I think, David, you can handle that. Good question. Okay, what's your preferred connection with the inverticoaxis and why? In America, we're enamored with conical connections just because we're gullible to clever marketing. But the connection that I showed here was a deep conical connection. It's basically the Astra TX connection. And I very much prefer that on single teeth because you get, in my experience, a better anti-rotational configuration and honestly a better seal than our external hex implants or even some internal hex. And so I think the easiest way to answer that is single teeth anteriors. I prefer a conical connection. But anytime you start to, that becomes a difficult thing to manage when you need to do bridge work. And so in my practice, we use external hex for multi-unit restorations, deep conical for single units. And that is why also with the deep conical, we have a little bit more of a platform switch. And so, in theory, I think we're getting better long-term tissue results around those. Do you routinely use passive abutments? I use them every single day for temporaries and for final restorations. Hopefully that, let's see. Hey, a question from one of my ex-residents referring doctors. How difficult is it to get comfortable with the technique of placing the angle-corrected implants in the anterior? So you have the right angle. That's an excellent question. My advice is to do what I did. I honestly didn't trust these angle correcting implants right from the get-go. This coaxis paradigm was presented to me back in 2011, and I used it extensively in full arch, fixed and removable, but I just didn't trust the long-term stability of the tissue over time. But now with the smaller connections on the platforms, we use it almost exclusively. So to answer your question, David, start with angle correcting implants on your edentulous cases, for your overdentures, for your full arch bridge work. And once you feel incredibly comfortable in those less risky, less aesthetic situations, you can start to move out into the aesthetic zone. Why not use multi-unit abutments? That's an excellent question. You can use multi-unit abutments if you want, but if the goal is to obviously optimize our ABCs, so aesthetics, I've seen quite a few cases where the multi-unit abutment is exposed at the gingival margin. That does not optimize aesthetics. If you look into biomechanics, you're using smaller screws, thinner sidewalls of abutments. They're not as strong. Of course, that's making the restoration thinner. We've had more issues with multi-unit abutments than going direct to platform. I know some of my colleagues will disagree with me with that, but if you're using angle corrections correctly with these implants, you're able to make much more predictable impressions because everything's parallel, and you're able to get much more predictable results direct to platform. That's why I prefer not to use them. But come to I have a whole slide series on the benefits and limitations of multi-unit abutments. Come to Africa and we can go over that. I'm trying to see here. We're getting a whole lot of questions here. Your final abutments, do they usually end up being tie bases or custom abutments for the anteriors? What they are passive abutments, so it's kind of a mix of both. I've had too many tie-based delaminations in my career. You know, I've only been in practice for 9 years. We've placed over 6,000 implants in that 9 years. We've restored far more because we restore implants that we don't place as well. But we've had quite a few tie-based delaminations just via volume of what we're doing. And so if you do more research on that passive abutment and find a lab that's very well versed in using it, you don't worry about the tie-based delaminations, and you get all the benefits of doing a custom abutment for less cost as well. Let's see, another question. Do you use ISQ testing during insertion exposure of Inverta? You know, I used to. That's an excellent question. I have a good colleague, friend of mine, Barry Levin, that loves ISQ. Periodontists does fantastic work. ISQ, in my experience, I don't believe is necessary. Basically, what that's testing is theoretical bone to implant contact. And in my experience, you should know that. If you take out a huge cuspid, for instance, and you drill along the palatal wall, and you place an implant, the whole implant almost goes into that socket before you start to torque it down, and then it suddenly torques out at a high torque value. You should know just by you know, doing the case that you have very little bone to implant contact. So I don't personally use ISQ. I haven't found it to be incredibly helpful. I find it more helpful to maximize bone to implant contact by engaging as much bone as you can. Longer implants, I'm a fan of 18mm implants, to be honest with you, and torquing them out to high torque rates. Let's see, any tips to share about digital and immediate low to full ceramic crowns? Do you think seating definitive ceramic crowns on Inverta could give predictable results? Well, if you're talking about a ceramic crown with a titanium base, such as in either a tie base or in a passive abutment, absolutely. There's, I mean, the Inverta, it's really all it is a 5mm implant with a 4mm platform, or a 4.5mm implant with a 3.5mm platform. So anything that you do with traditional implants can be done with Inverta. Anything you do with traditional implants can be done with coaxis. These are just platforms. And, you know, I don't, these implants are so amazing because I grew up or trained in the kind of the era of, well, the doctor put the implant where the bone is. And I can't think of a better designed implant to put the implant where the bone is, but still maintain the platform where the platform is, so you're not fighting over those two. So by all means, any crown that you feel comfortable restoring is fine. Let's see. On an all-on X scenario, without tabling and not flapping, what has been your experience with using an external hex with a 24-degree coaxis? Bone loss around these, are you placing these subcrestal? Are you also restoring direct to fixture? Yes, well, that's a loaded question. I try and restore everything direct to fixture if possible. Yes, you will if you're not careful. 24-degree coaxis implants for the longest time were 5mm in diameter. So if you did not maintain a 2 to 3mm gap and graft it well, you would get recession around those implants, but you'd get recession around any 5mm implant. So with the advent of the 4mm diameter 24-degree coaxis, as long as we're maintaining, my advice is 3 to 4mm is what I would propose of a gap. Grafting it, we're placing those at the exact same level as a single anterior tooth, so 3 to 4mm deep to the predicted free gingival margin, and we're going direct to platform. Let's see, how many implants are you placing in the edentulous maxilla for fixed? Every other week we have a case like that. I mean, that's kind of a loaded question because, you know, I really like that question because that depends on the patient. I feel like we're forcing fixed restorations into every patient's mouth, and I wish I had time to do more, but we've had multiple patients that have chosen removable and have been more happy with it. In fact, there's a study out there that contrasts 10 patients that are put in removable full arch, 10 patients that are put in fixed, and then they flip-flop them, and 60% of the patients were more happy with their removable rather than fixed. So there's this kind of stigma that everybody wants fixed, but once they find out the benefits and limitations, more and more people actually prefer removable if done well. So we just did a case, well, before the whole pandemic, you know, at least weekly, we're doing a fixed maxilla. Let's see, another question. In an upper anterior single case, is there a significant difference between inverted coaxis external hex and inverted coaxis deep conical connection? There's honestly, no, the answer is no. My opinion and experience with this, and according to the literature, yes, external hex years ago had a bad rap for screw loosenings, but you have to think more about that. Most of those were loaded non-axially because they weren't coaxis implants. More importantly, this is very well documented in the literature, the milling tolerances back then were upwards of 200 microns, and now we're all the way down to 2 microns, you know. So I haven't had any more screw loosenings in external hex than I have in deep conical, but I believe that's because we're placing these implants to be axially loaded and restoring them correctly. That's the last one, I think, David. Oh, no. Want me to keep going, David?
I'm aware that you might have a patient in the chair as well that needs some implants, but if you've got a few more minutes, absolutely, if you've got the time.
Okay. Yeah, I don't have a patient for another hour, so.
Oh, okay.
Let's see. Would you consider doing an inverta with facial bone loss, or would you consider doing bone augmentation with inverta or second face? That's perfect. That's an awesome question, and I encourage you to tune in to Barry Levin's. Is he in 2 weeks, David? Do you know the outline? So
yes, he's on the 6th of May.
Okay, so 6th of May, that'll be a perfect one for you. This is Charles, to watch. The answer is, depending on the patient's compliance, systemic and local factors, yes, you can do an immediate. You are at higher risk, so if you don't have, you know, the non-invasive, Barry will talk about the dermal apron technique, which is probably the least invasive way to graft a compromised facial plate, and you don't feel 100% confident and comfortable doing it, then of course abort. But watch Barry, he'll be able to answer that question for you. But the simple answer is yes, as long as you use a non-invasive grafting technique. Next question: for a maxillary full arch removable cases, are you using a bar and splinting the implants? Awesome question. That's another thing that we go over in another lecture. The literature is very clear on you can use either solitary abutments or splinting. When would we use splinting? Well, if we're skeptical of the bone quality and over time, if we have thin bone, if we have small implants, if we have short implants, ultimately, if we have a patient with excessive occlusal forces, those are the cases that we would splint. But I do the best I can to not splint, just because that makes it difficult for the patient to clean, and also by the time you stack all those components prosthetically, increases the chances of delaminations and problems. Are you grafting the gap? Yes. Anything that I can fit bone in, I graft. When you perform full arch fixed cases, how do you maintain hygiene direct to fixture? Same way you remain hygiene direct to fixture on a single tooth there, as long as you have excellent emergence profiles and create a modified ridge lap that the patient can use. Water pick, Sonicare, floss threaders. You know, full arch fix design shouldn't be any different than 3-unit fixed designs. And I think that's the last question, Dave.
Well, thanks, Dr. Egbert. Absolutely awesome. I can't, what can I say? Brilliant presentation, and I love the answers to the questions as well. You mentioned the US-like bright smiles. I think the clinicians is just as bright. But thank you again. If I can just take this time to introduce next week's webinar. So every Wednesday at 11 a.m. it will be Dr. Gary Morris and Mark Steinberg, the Prosdo oral surgery or MaxVac team, and they'd be discussing optimizing outcomes and practice efficiency, utilizing less invasive accelerated implant therapy protocols. Another one to look forward to. In that, Dr. Egbert did allude to the fact that this is a teaser to his presentation in South Africa later this year. I suggest earmarking that date in the diary and having something to look forward to. But Dr. Egbert, thank you very much from the Southerns team.
You're welcome.
Everyone have a good day, and we'll see you next week.